Today's topic for discussion is the ventricular septal defect. The ventricular septum, as you all know, is the partition between the right and the left ventricle. But it is not a very simple structure. It is not a simple muscular partition. It is a complex partition, and we shall see the details of it as we go along. Now, ventricular septal defects were first described by Roger in 1879, and in those days it was called Malady de Roger in his honor. And today it is a term which is still used, particularly for small asymptomatic VSD. In 1898, Eisenmenger described VSD with cyanosis and pulmonary hypertension, and since then this complex has been termed the Eisenmenger's complex. So before we actually go on to the pathoanatomy of the VSD proper, it is good to understand something about the development of the septum. So as I told you, septation of the ventricles is more than a simple muscular partition. It is not a straight structure. It is a sigmoid-shaped structure. And the ventricular septum is a complex structure because it is partly muscular and partly fibrous. It is formed by alignment of the muscular partition of the ventricular, primitive ventricular chamber, by the outflow tract cushions, and by the atrioventricular cushions. So all these structures contribute to the development of ventricular septum. So the ventricular septum is 3 parts muscular and 1 part fibrous. Much of the septum is of course muscular. This is the cut open right ventricle. Here is the inlet portion, the trabecular portion, and the outlet portion. The musculature from all these portions, inlet, trabecular, and outlet, all contribute towards the septum. But right here, where they come together, is the fibrous septum. So let us recapitulate a little bit of the embryology. Now, to begin with, as you know, the heart is a straight tube, as we saw last time. So this is the sinus portion. The venous contributions come into here, this chamber, which is this venous sinus. Then we have the primitive atrium, the primitive ventricles. Between the primitive atrium and ventricles, we have the atrioventricular canal, and it has cushions, endocardial cushions. The anterior and posterior fuse together and form the septum intermediate. Then we have the primitive ventricles. This primitive ventricle leads to another chamber which is known as the bulbus cordis, and this contributes to the outflows of both the ventricles. Beyond the bulbus is the truncus arteriosus, which will develop into the 2 main arteries, the pulmonary artery and the aorta. Now the septum intermedium, as we saw last time, divides the atrioventricular canal into a right and a left orifice. Now to begin with, the heart is a straight tube, but then the tube bends to the right, and this process is known as looping. So this is the looping of the ventricles. And the primitive ventricles are present in this loop portion of the heart tube. Here is the primitive right atrium, the primitive left atrium. This is the atrioventricular canal with the endocardial cushions. Here we have the outflow portion, the bulbus cordis, with cushions again in it. Beyond it is the truncus, again with cushions. So once the straight heart tube loops, it has an inner curvature and an outer curvature. This seems to be a little more busy slide with lot of details. So here is the atrioventricular canal, the primitive right atrium, primitive left atrium, and this whole part is actually the primitive ventricle. This part will give rise to the primitive left ventricle. This part will give rise to the primitive this will give rise to the left ventricle, and this part will give rise to the right ventricle. And then this leads to the conus, and then subsequently the truncus. Now, as growth happens, this part of the ventricular mass starts going out like this. Here also, this part starts going out like this, and they fuse together in the center to form the interventricular septum. So this will be the muscular interventricular septum formed due to the outgrowing bulge of the right ventricle, the outgrowing bulge of the primitive left ventricle. So diagrammatically, if you see, this is viewed from the right. You have the red part, which is the muscular interventricular septum, which has grown up from the apex towards the endocardial cushion, but doesn't quite reach the endocardial cushion. The outflow, again, there are bulbar ridges, and beyond that you have the truncal ridges. Now the bulbar ridges come together like this, and they grow downwards towards the endocardial cushions. In the meantime, the truncal ridges or cushions are also fusing, but they fuse in a spiral manner, and therefore you find that the pulmonary artery and the aorta are twisted around each other. So this fusion, this aortopulmonary septum, is nothing but fusion of the truncal ridges in a twisted manner. So then you have this gap here, and this gap is the membranous septum. So this is the muscular septum, and this gap that is there is the membranous septum. This membranous septum has to be closed, and it is closed by cells proliferating from the endocardial cushions, a few mesenchymal cells from the bulbar cushions, and also a few mesenchymal cells from the muscular interventricular septum. So here you have a further advanced picture of the ventricles. Here is the muscular interventricular septum. This is the primitive left ventricle, primitive right ventricle. These are the bulbous cushions, and then you have the truncal cushions. In between, as the muscular interventricular septum grows up towards the endocardial cushions, there is a little opening there, which is the bulboventricular communication or the interventricular communication. Now, the membranous septum. See, if you look carefully, you will notice that the interatrial septum and the muscular interventricular septum are not aligned in the same plane. There is a little distance between them, and this distance is covered by the membranous septum, that is fused atrioventricular cushions, that is the septum intermedium, and proliferation of cells from the endocardial cushions joins the interventricular septum. So the posterior part of the muscular interventricular septum, this part actually separates the primitive right atrium from the primitive left ventricles. The anterior part of this septum is between the two ventricles, but since it is not a straight structure, there is no proper alignment, you have all this complex arrangement. So the membranous septum has an interventricular portion and an atrioventricular segment. So you see here, this is a diagrammatic representation. This is the membranous septum, inlet component, apical trabecular, and outlet component. So it is a very small structure here that you see, which brings together all these three segments of the muscular septum. So when we are looking at the ventricular septal defect now, we have to understand the anatomy of the interventricular septum, which we have gone through. Another important part is anatomy of the conduction system, the AV node and its distribution, and the different types of VSD. Now, if you look at the right ventricle, this is the opened out right ventricle, the right atrium. Where exactly is this membranous septum situated and what are its landmarks? The membranous septum is covered by the septal tricuspid leaflet. So it's at the junction of the septal and the anterior tricuspid leaflet right here. And one of the important landmarks of the membranous septum is the medial papillary muscle, and we shall soon realize what is so important about this medial papillary muscle. So in a normal heart, the membranous septum is generally covered by the septal tricuspid leaflet. So this is a four-chamber view, the muscular interventricular septum. This is the tricuspid valve, the mitral valve. See, the mitral valve is attached at a much higher level than the tricuspid valve. And this is part of the membranous septum. See, this is the interventricular septum. Somewhere here, a little behind, will be the interatrial septum. So they are at an angle to each other, and therefore you have this fibrous septum or the membranous septum between the two ventricles, as well as between the right atrium and the left ventricle. So the tricuspid valve actually is attached to the fibrous septum, and therefore this is the fibrous septum, very close proximity to the aortic valve, and you will see that there is an atrioventricular portion and an interventricular portion of the membranous septum. In infants, the atrioventricular component is quite significant. However, as the child grows, the interventricular component of the fibrous septum becomes more dominant. Now, how do we see it from the left side? On the left side, you will see the membranous septum here as a fibrous structure between the right coronary and non-coronary aortic sinus. So it's in very close proximity to the fibrous continuity between the mitral valve and the non-coronary cusp. The other important part is the conduction system. Now, if you look at the right atrium, we have the AV node at the apex of the triangle of Koch. From the AV node, you have the bundle of his, common bundle of his, and central fibrous body. So the bundle of his penetrates the central fibrous body and then comes to lie at the crest of the muscular interventricular septum, traversing partly through the membranous septum. Once it comes to the crest of the interventricular septum, it divides into the right bundle and then into the left bundle. And therefore, it is very closely related to the membranous septum. And therefore, defects in the membranous septum, you will obviously have to see how the conduction system is oriented. So see, this is the right atrium, the right ventricle, septal tricuspid leaflet. electrode will pierce the central fibrous body, come down to the crest of the ventricular septum, and then divides into the right bundle and the left bundle. So the right bundle will then divide into branches across the right ventricle. On the left side, likewise, it will divide across the interventricular septum. This is the membranous septum. So the branching takes place on the crest of the ventricular septum between the right coronary and non-coronary cusp. So ventricular septal defects are a fairly common congenital anomaly. They may occur isolated or associated with other cardiac anomalies. How do you categorize holes in the ventricles, interventricular communication? The simplest ones are the muscular defects, where the defects have a totally muscular border. This, however, constitutes only about 15 to 20% of the types of VSD. The more common one is the perimembranous defect. And the part of the fibrous border of this membranous defect is the fibrous continuity between the leaflets of the tricuspid and aortic valves. And often you will see a remnant of the membranous septum on the posterior inferior rim of the defect. So perimembranous defects are the most commonest type of defects. Around 70 to 80% of the ventricular septal defects are perimembranous defects. About 15% may be muscular defect, and the least common is the Juxtaarterial defect or doubly committed defects. Here there is fibrous continuity between the leaflets of the aortic and pulmonary valves. So, why do we need to categorize these different types of VSD? In isolated defects, or even when it is associated with lesions like TOF, where it is an inherent part of the disorder, DORV also it is inherent, tricuspid atresia, etc. The most important part is because of its relation to important structures, the conduction system and the arterial valves. Now we are looking at a simple perimembranous defect. So here we have the triangle of Koch, here we have the AV node, and then the AV node pierces the central fibrous body common bundle of His. It comes down across the crest of the ventricular septal defect. Here would have been the membranous septum. Now it is, you see here, the medial papillary muscle is attached here. The importance of the medial papillary muscle is that the bundle of this penetrates the crest of the septum at the attachment at the level of the medial papillary muscle, and after that it divides into the right and the left bundle. So the medial papillary muscle is important because it indicates the point where the common bundle of this penetrates the muscular interventricular septum. And this, the position of this medial papillary muscle will differ depending upon the types of membranous defects. So a surgeon is generally looking from the right side, and it will be on the right hand margin as he is operating. So this is the four-chamber view of a perimembranous defect. Muscular interventricular septum, right ventricle, left ventricle, tricuspid valve. So there is very close tricuspid aortic continuity, and here is the membranous, perimembranous defects. Why do we call it perimembranous and just not simple membranous defects? Because oftentimes we see a part of the membrane still present at the edges of the defect. So perimembranous defects can have an inlet extension, trabecular extension, and an outlet extension. They can point this they can point this way, or they can point that way. So here are the perimembranous defects. This is a perimembranous defect with inlet extension. It is going towards the inlet portion of the right ventricle. And if you see here, this is where the medial capillary muscle is attached. So if you have the AV node here, it has to come, the common bundle has to come all the way down here to pierce the crest of the ventricular septum. So the surgeon has to be very, very careful all along this course. This is the trabecular type of membranous defect. The defect is pointing towards the apex of the right ventricle, and you see here the medial papillary muscle is just here. So it's very short distance that the common bundle of this has to travel. This is the outflow type of membranous defect, which is pointing towards the right ventricular outflow. This is the pulmonary valve. Here again you see the medial papillary muscle is just attached here, very close to the its origin from the central fibrous body. So this is from the left side, the inlet type of VSD, the outlet type of VSD, and the trabecular part of the VSD. So here we have trans-illuminated the membranous defect to show you the defect, and all this part that you are seeing is the remnant of the membranous septum. So it's not a complete absence of the membranous septum. Many times a large chunk of the membranous septum still remains. So as I told you, this is the inlet type. The conduction system has to traverse all the way up to here, to the medial papillary muscle. In the trabecular type, it has to come only here. And in the outlet type, it has to travel a still more shorter distance. So this is from the left ventricle. Here is the course of the outlet type of perimembranous defect. Here is the course of the bundle of His before it divides. This will be the course of the bundle of His as before it divides. This is the trabecular part of type of VSD. And inlet, this is the course of the bundle of His. Now do perimembranous defects close? Many of the defects which are related to the septal tricuspid leaflet sometimes close, and they close by plastering of the septal tricuspid leaflet. And if there are small inlet or trabecular defects, then the septal tricuspid leaflet can plaster across those defects and close it, and also it can close by ingrowth of fibrous tissue. So here is a perimembranous defect. You see the septal tricuspid leaflet has plastered and almost closed the orifice. From the left side, here is the defect, and you can see the septal tricuspid leaflet filling the VSD. So people also talk of aneurysm of the membranous septum. Actually, this is nothing but fibrous tissue tags around the defect. Maybe it is derived also from tricuspid septal leaflets. And this, therefore, the tricuspid leaflet can close inlet and trabecular type of defects. Here you see, from the right ventricle, this is the septal tricuspid leaflet almost closing the defect and forming a little bulge. Therefore, it is called aneurysm of the membranous septum. example of an opening, and there is ingrowth of fibrous tissue closing the gap. The other way of closing the defect is by aneurysmal prolapse of the right coronary cusp, particularly seen in outlet type of defects. Prolapse of non-coronary cusp is also possible, and these prolapses may partially or completely close the defect. For example, here is the perimembranous defect, and you have the prolapse of the aortic valve cusp closing the VSD. Here you see the right coronary cusp almost sinking into the VSD and closing it. So it is prolapsing into the VSD and closing the defect. So in all types of closure of VSD, there is contraction and fibrosis around the edges of the defect, which also contribute significantly to closure of the defect. But remember, this also provides a nidus for the development of infective endocarditis, as we see in the next slide here. So here is a VSD which is completely closed by a mass of infective endocarditis. This cauliflower-like mass is nothing but infective endocarditis. Here again from the left side, here you see lots of infective endocarditis of trying to obliterate the orifice. So along with the septal tricuspid leaflet, if there is endocarditis, that will also try to block the perimembranous VSD. So what are the dangerous areas which the surgeon has to be careful? It is at the apex of the triangle of Koch, the point of penetration from interradial septum to aortic outflow, the non-branching bundle and the branching bundle. So, of the three defects, the outlet defect is the safest as far as surgeon is concerned, particularly because it is the distance that the bundle of his has to travel is very minimum. Then we have trabecular defect, and least popular is the inlet type of defect because the common bundle of his has to traverse a long way to reach the medial papillary muscle. Now, if there is prolapse, it can cause also aortic valve damage. Sometimes there is a good ridge of tissue separating the RCC right coronary and non-coronary cusp from the defect. These are generally seen in the outflow type of membranous defects, and this ridge of tissue is very often part of the ventricular infundibular fold. Tricuspid valve per se have no conduction tissue, but they can cause valve dysfunction. Sometimes they can also be valve tear. The next type of defect is the muscular VSD, and muscular VSD can be present anywhere in any region of the muscular interventricular septum. So here we have in the inlet portion, in the trabecular portion, all these yellow areas are muscular VSDs. In the outflow portion, etc. They are rimmed by muscle all around. So they are simple to identify. Here, this is the right ventricle. This is an inlet muscular defect. This is the pulmonary valve. So this is again very close to the outlet septum. This is in the apical part of the right ventricle, and sometimes you will see multiple small little openings, sieve-like. So this is known as a Swiss cheese type of muscular VSD. So from the left ventricle, you see it as a simple small hole in the muscular interventricular septum. Here you have multiple defects in the muscular interventricular septum. Here again, a muscular interventricular defect surrounded by muscle on all sides. This is from the right ventricle. Again, a muscular interventricular defect, the same thing as you see here. The last category is the subarterial or juxtaarterial VSD. Now, if you look at a normal heart, the pulmonary valve is supported by a sleeve of subpulmonary infundibulum. This is totally muscular. The subpulmonary infundibulum is totally muscular. In contrast, the aortic valve, it is supported by a ridge of tissue which is partly muscular and partly fibrous. And when there is a complete subpulmonary muscular infundibulum, it raises the pulmonary valve away from the body of the right ventricle and also separates it from the leaflets of the aortic valve. So a subpulmonary infundibulum will push the pulmonary valve upwards and anterior, and it is slightly above the level of the aortic valve. So here you see the aortic valve is wedged between the pulmonary outflow as well as the right ventricular inflow and the left ventricular inflow. The aortic valve is always squeezed tight between the right ventricular outflow and the atrial chambers. So when there is a fibrous continuity between leaflets of aortic and pulmonary arterial valve, that means the pulmonary arterial valve does not have a complete muscular infundibulum. And this because the aortic sinus is thereby no longer wedged between the leaflets of pulmonary valve. Pulmonary and aortic valve are almost at the same level. Now, the juxtaarterial defects, that is subaortic and subpulmonary defects, are for some reason more prevalent in Asian countries. And as I told you, the septal component of the freestanding infundibular sleeve, which normally supports the pulmonary trunk, is seen in other types of anomalies, say truncus, etc. And all these defects share a common genetic background, that is the 22q11 deletion. Therefore, this deletion is more prevalent in the Far Eastern population, and therefore it may be because of this reason that we see more of juxtaarterial defects as compared to the Western population. So this is the subarterial VSD, the pulmonary valve and the pulmonary artery, and here you see in the outflow the spawn defect. The same defect as you see on the left side. This is the aortic valve, and here you find the defect. This defect is a little more anterior than the perimembranous type of VSD. Here you see the this is the aorta, pulmonary artery, and you see the fibrous continuity between the aortic and the pulmonary valve. Here again you see the aortic pulmonary valve continuity. Again, a subarterial type of VSD. This is seen from the right side. You can almost see the pulmonary valve, which is this plastic kind of prolapsing into this VSD. So these are the aspects of the perimembranous, muscular and the juxtaarterial type of defects. What happens to the clinical course and prognosis? Small defects. What will you term as small defects, which are less than one-third the size of the aortic root. They generally have an excellent prognosis. 75% of them show spontaneous closure within 2 years of life. However, there may be complications like infective endocarditis, aortic valve insufficiency, or cardiac arrhythmias. Moderate size defects, which are half of the aortic root size. Here, there is a risk of heart failure, particularly between the first 6 months of life. But generally, the RV pressure is normal or mildly elevated. A large defect, which is the size of the aortic root. Here, there is a risk of heart failure, associated pulmonary infections, a raised pulmonary vascular resistance, and therefore increased mortality. It is in these cases particularly that surgery should be done before 2 years of age because you have less chance of developing pulmonary vascular resistance. Older the patients, the more the patients have progressive persistence of pulmonary vascular resistance, which is then difficult to manage. So VSDs with raised pulmonary vascular resistance should have a repair done between 3 months to 12 months of age, so that they can preserve a good LV function and there is regression of hypertrophy. How do you repair VSD? Of course, the standard method so far generally has been surgical repair, open heart surgery. You put a patch which closes the defect. However, today it is the day of catheters. So you can use catheter devices, either a mesh device to close the defect, or you can use even the Amplatzer type of devices to close the defect. It is a little more difficult than repairing ASD. Then they have developed a hybrid procedure which uses surgical and catheter-based techniques. So you access the heart through a small incision, then you introduce the device which is placed through the incision to close the ventricular septal defect. So today the options are either surgical repair, a direct catheter device, or hybrid procedures. So this is the last slide. Here we have a Dacron patch placed in the VSD, perimembranous VSD. This is the left ventricle. These are pictures of the right ventricle with a Dacron patch here. These are all perimembranous VSDs. Here again a Dacron patch here. You will see that it is just behind the septal tricuspid valve. So with this, I come to the end of my presentation, and if you have any questions, you may please put them in the chat box or whatever needs to be done. Thank you.